Hello, once again Ijaz Hidayat with new topic, with new talk, and today's my talk is related to Ecmo. What Ecmo stands for? Ecmo stands for extracorporeal membrane oxygenations, means extracorporeal means outside the body. Membrane is the artificial lung where we oxygenate the blood. The process of oxygen providing to the cells and delivering to the patient's body. So there's a two type of ECMO available. Veno arterial ECMO or veno ECMO. So in a veno bypass or VA bypass. So if your lungs is affected and is not capable to perform their duty, their job, so the meantime we are helping to the lungs. Meantime there is a treatment going on to recovering the lungs. We maintain artificial we maintain artificial circulation, and we are trying to support to the lung meantime, and this can be for a couple of days, couple of weeks, or a couple of months. So this is called the Vvx support. So we are supporting to the lungs. On other hand, when your heart is not in a good condition or very sick heart, and sick heart itself is not capable to perform its work, so heart work is to pumping the blood. So then we maintain systemic artificial circulation through the oxygenator with the tubings, and this called the VA ECMO support. So in a simple words, VA ECMO is for the heart support, VV ECMO is for the lung support. It can be a VAV ECMO support or VVA ECMO support. So this is a huge topic. I will not going to discuss this. Today I'm going to just focus for the VV ECMO support. So why we need a VV ECMO support? And in a VV ECMO support, we are going to give support to the systemic to the respiratory side, to the right heart support, to the lung support. So meantime the lungs get recovered. So what is the indications for the VV ECMO? The most common indication for the VV ECMO is ARDS, means acute respiratory distress syndrome. On the other hand, the patient when having a severe pneumonia, this can be one indication. Pulmonary contusions, then there is the bridge to transplant of the lungs. So the patients who need a transplant for the lungs and they're waiting for the donors, you can use the VV ECMO support. In that meantime, then you get a lung and you can go for the heart transplant. And nowadays, where there is a COVID, there is so much support to the lungs with the support of the ECMO, and we save so many lives during the COVID era. So the criteria for our VV ECMO support is if the patient's reversible from the respiratory failure, yes, he can be the candidate for the VV ECMO. If the patient's More score is more than 3 and above, yes, it can be the candidate for the VV ECMOs. Patients having pH below than 7.2 due to the hypercapnia, yes, the VV ECMO support can be help to recovery of the patients. Or if the patient is on ventilators and it is less than 7 days with the conventional support and there is no recovery, patients can go for ECMO support for recover their lungs. So these are the criteria of our ECMO support, but there is a contraindication for ECMO support, and there are some patients having the malignancy, patients having the unwitnessed cardiac arrest, and severe heart failure patients are the contraindication for Vvx Mode. If you talk about the relatively things, this is our absolute contraindications, and there is a secondary which can be if the patient's age is more than 75 years. So this patient is not suitable for the Vvx Mode, but it is like it's up to you if you want to do it or not. And if the patient has multiple organ failures, it can be a relative contraindications, and patients having like a neurological injury, it can be the reason for contraindication of Vvx Mode. What are the equipments we required to initiate Vvx Mode? Of course, as you're the perfusionist and you know, to initiate VV bypass, VV Ecmo or VV Ecmo bypass, you need a centrifugal pump, and centrifugal pump is with a different brand with a different manufacturers like Cardio Help. We have the Levotronic Centromag pump is available in the market. There is a Xenius pump available in the market. There is a Medtronic pump available in the market. Rotaflow PLS pump is available in the market. So there is a different type of the Ecmo machines are available. It's up to you which machines you are going to be used. Of course, you need the oxygenator having the long life because you have to run a long bypass. So you need a oxygenator. You need an oxygenator with a long lifespans. Like in the market, you will find the Ecmo oxygenators with a different brand, with a different names, and you can finalize which is suitable for your hospital or for Ecmo therapy services. So there is the oxygenator with the polymethylpentine material is going to be used, and they is specially designed for the Ecmo. So you have to get that oxygenators for biolin coated tubes and air mixer blender and the accessories required for to initiate Ecmo. So now we'll come up. So normally is Ecmo, the Vvx Mode. So today's target is to just cover up the Vvx Mode. So Vvx Mode normally is initiating with the cannulation of the femoral vein and jugular vein. So we're getting volume from the femoral vein and returning back into the femoral jugular from the jugular vein. Or it can be from right femoral vein. We are getting volume and we are returning back to the left femoral, and the cannula will going to till the end of the right atrium. So we are keeping always the cannula. If you're doing the fem cannulations, so your access cannula should be lower and your return cannula should be on the upper. So there should be the 8 to 10 centimeter difference. So the return cannula should be inside the right atrium, and your IVC is near to the hepatic IVC. So if it is near to each other, there is a chance of recirculation. So this is we're going to discuss in a further talk. Okay, so before going on pump, your ACT should be around 200. Perfusionist should be in a control to check the whole circuit. It should be properly secure and in a functional mode. Your circuit and your machine should be capable to produce 4 to 5 liter pump flow during your Ecmo sport. Gas flow you initiate initially with the 1 with the ratio of 1. I mean, if your Ecmo flow is 4 liter, so keep your sweep gas at 4 liter. Our aim is to maintain oxygen saturation of the patient's SpO2. So the patient's saturation should be above than 85. So it's mean your Ecmo is working fine. During Ecmo, we need to manage the circuit, and we need to manage anticoagulations, and of course circuit management, blood gas management, and anticoagulation management. For the patient side, our target is to keep the pH 7.3 to 7.45, PCO2 35 to 40 millimeter per mercury, and PO2 initially you will find out like in 40 to 60 millimeter per mercury. And as soon as the lungs start recovering and your sweep gas going down, the saturation of PO2 will going to come up so it will take time. The time you initiate ECMO, after initiating ECMO, always check the post-oxy of the patient, and the most important part is the time of initiating ECMO. Your sweep gas is the similar like your pump flow, and your FiO2, the fraction inspired oxygenation, should be on 100%. And then you can check the post-oxy of the patient and keep this as a baseline of the post-oxy, and on daily basis you check the trend of your post-oxy. The patients having non-bleeding, the patient with the non-bleeding, our target was to keep the appetite around 40 to 60. The platelets count should be around above than 100, fibrinogen above than 1.5, INR should be 1 to 1.5 in between, like that. The patient with the bleeding and on ECMO, our appetite should be around 50 to 60. Platelets, if it is below than 100, you need to transfuse. If fibrinogen level is below than 2, you need to transfuse cryoprecipitate. Or if your INR is below than 1.5 or 1, you have to keep transfuse FFP and try to keep your INR below than 1.5. For the circuit management, if your patient is on ECMO, you need to check tip to tip. Tip to tip means from access cannula, starting and checking from the access cannula, tubings, go to the oxygenator, pre-membrane pigtail, post-membrane pigtail, sensors, then the tubings, and then till the end of your return cannula, tip of the return cannula. So you have to go A to Z, mean tip to tip checking of your circuit. If you find any clot, the change of the color, or any stagnancy you notice, then you have to do some intervention on the spot. Then there is for the circuit tip to tip, there will be pressures of the ECMO. We have 4 type of pressures available on ECMO machines, like a pre-membrane access pressure, pre-membrane pressure, post-membrane pressures. The difference of pre and post is the TMP delta pressures. So you have to see the baseline of your TMP, baseline of your pre-membrane pressure, baseline of your post-membrane pressure, and it should be documented. Gas flow, the baseline of the gas flow, then integrity of the circuit and oxygenator should be checked continuously and monitoring on a daily basis, and document this. For the access cannula or return cannula, if there is a connector, there should be tie in between the connector and the tube, and your line should be secured properly, that your cannula will not dislodge at any moment or bedside manipulations time. As I mentioned, for the circuit of the ECMO, you have 4 pressure. Your first pressure is called the access pressure. Access pressures mean negative pressures, because we are sucking from the blood. So you will find a negative pressure there. Your negative pressure should not more than 100. So 60 is your ideal pressure. From 60 to 100 is acceptable. If your excess pressures go more than 100, then you need to do the intervene. You have to check what was the reason why your excess pressure is higher side. So if your excess pressure is higher, there is a chance of high RPM. There is a chance of bleeding, internal bleeding of the patients. There is a chance the patient is hypovolemic. Patient is awake, and there is a kinking of the access line. This can be the cause of your high pressures. So what was your immediate reaction or action if you find the access is higher side? So first of all, you decrease the RPM. Number 2, check the sedation of the patients. Number 3, you can check the status of the volume of the patients. Number 4, check the hemoglobin hematocrit, if the patient is bleeding internal or not. So then act accordingly. Then you have the pre-membrane pressure. Pre-membrane pressure is always higher than your post-membrane, because the pressure is generated by the pump, and the blood which is entering prior to the oxygenator, you will get a higher pressures. If your baseline is, like example, 150, and then suddenly your baseline pressure, pre-membrane pressure become 300, so it means there is some obstruction in your oxygenator. It can be the cause due to the clot. So you have to check physically if there is any clot. But if there is a post-op membrane pressure is higher, it means there is a occlusion on the patient side. So then you have to check the patient sides, the cannula and the tubes, either is kinked or not. So TMP is your baseline, the difference between pre and post. So always you will find the baseline. If your baseline is double, then if the TMP is double than your baseline, then you have to check, maybe your oxygenator is going to be failed. For that you need to do the post-oxy of the patient, trend of the post-oxy, and gas transfer formula. If the gas transfer formula showing the transferring of the gas through the oxygenator is lower as per required, then you need to change the oxygenator electively. Negative pressure, excess pressure I mentioned. If it is continuous, excess pressure is higher, there is a chance of cavitations. So to prevent cavitation, decrease your RPM, check patient if needed any volume, and always keep your negative pressure around less than 100. Then we'll talk about the flow. How much the flow required for the Ecmo? Normally like 50 to 80 cc per kg per minute. The maximum the flow, the target of our maximum flow is to keep the patient's saturation around above than 85. This is our target. So now we'll talk about the blood flow management. If the patient's blood flow decrease, for example, your flow was 4 liter and suddenly it come to 2 liter. So your flow was 4 liter with the RPM 3000 example. Now your RPM is 3000 but flow come to 2 liter. So what can be the reason, and what will you find on Ecmo parameters? So you will find your excess pressure will come up, and you will find some chattering, the shivering of the tube, chattering of the tube. Reason can be patient decrease for the preload, patient get hypovolemia, or maybe there is chance of your cannula positioning or kinked. So you need to check the position of the cannula, kinking of the tube. You need to check if the patient is kinked or not. If patient is not kinked, still you will find the chattering, then you need to transfuse some volume to the patient, because maybe patient is losing from internal side. Then if your RPM is the same but your flow come down and you find your TMP is higher, what will going to happen? What can be the reason? The reason can be your oxygenator get clotted, and there is a chance of clot in the circuit in the oxygenator, and you need to change the oxygenator. If your RPM is the same and your flow come down and your pre-oxygenator and post-oxygenator pressure is higher, so it's mean your return line is kinked or clamped somewhere else. You have to check. So these are the small examples in case of the low flow with the same RPM, how you going to troubleshoot and how you can to overcome this issue. And now we'll talk about the air mixer blender is very compulsory component of the Ecmo circuit for the Vvx Mode. And you know, in air mixer blender, we always keep the FiO2 fraction inspired oxygen at 100%. We keep the sweep gas around according to your gas flow, pump flow. And as soon as the patient start recovering, we are starting to decreasing the sweep gas. So sweep gas is the parameter. The sweep gas is one of the indicator for recovery of your lungs. As soon as sweep gas is coming down, and oxygen is coming up, so it's mean your lungs start recovering and your sweep gas is coming down. The sport of the the gases from the oxygenator will reduce and lung itself start working. So with the sweep gas, we are removing CO2. With the fresh inspired oxygenation, we are giving oxygen to the blood. We always keep FI to 100%, and by decreasing the weaning of Vvx is with the decreasing of your sweep gas. So this is clear. Hope it is clear for you. Then we'll talk about the recirculations. The most common factor is recirculation in the Vvx. Recirculations mean that the two tubes which is sucking blood and returning back both are near to each other. So instead of giving oxygenated blood to the right atrium, we are returning back to the access cannula. So the oxygen is not providing to the tissue, not to the system. So this is called recirculations. How will you find out there is a recirculation? The color of your access line and return line will be the same. The patient saturation will decrease, and your central venous saturation on Ecmo machine will come higher. So these are the indicators which show there is a recirculations. So in a recirculations, as I mentioned, your SpO2 will increase, your patient saturation will decrease, and there will be no difference in the color of the tubes of the Ecmo machines will be the same. Reason can be your pump speed is higher as much the patient required. Cannula position can be the reason that the both cannula is near to each other. There will be low cardiac output can be the reason, or intra-abdominal pressure increase can be the reason of your recirculation. So these are the reason of recirculation. There is a formula in which you can calculate how much the Ecmo circuit recirculation is there. Like for all the Ecmo patients, 30% recirculation is acceptable. But if your recirculation is more than 30%, then you need to either adjust your cannula, or then you have to look other facts why there is a recirculation. So the formula for the recirculation is pre-oxy saturation minus patient SpO2 divided by post-oxy saturation minus SpO2 into 100. If with this formula your outcome come more than 30%, it means these are patients having a recirculation. Then what you have to do, what is your management? Decrease RPM, increase the distance between the cannula, or either you maybe need another drainage cannula. So these are the management. So in case if you find low SpO2 on your Ecmo machines, it can be so what can be the reason, and what are the management? What is the management? So if you have the low SpO2, maybe your air mixer blender is not working, or your line is disconnected. On other patients, treated increase the metabolism. The patient's metabolism increased due to the sepsis, tachycardiac, sedation, or temperature. These can be the reasons for your low SpO2. During the Ecmo, you will find sometimes there is a hypoxia, worsening of hypoxia. The reason can be the gas connections, decrease of the pump circuit flow, recirculation, decrease in your FiO2, oxygenator can be the causes, or maybe increased cardio output will be the cause of worsening hypoxia. What can you do? You can size your oxygenator with the help of air mixer blender, or you can decrease the temperature of the blood. This is the best way to manage the worsening hypoxia. Now there is other term. There is a worsening of hypercapnia. Hypercapnia is all the causes can be also the gas connection, decrease of your sweep gas flow, pump flow decrease, oxygenator integrity. Of course, with this same you have to do the psi, or you need to decrease the temperature of the blood. So before weaning off, you need to check the patient's X-ray, the status of the lungs, patient's lungs 100% test, or if the lungs is getting tidal volume around 4 to 6 ml per kilo, or of course EtCO2. So all these are the way to check the lungs strategy. and come off from the Ecmo support. So after, as the most important part, so when patient's lungs are recovered, so at least 24 hours you just switch off your sweep gas and keep ECMO circulation on. And if still the patient saturation is maintaining very well, the patient is ready to wean off from the bypass. Hope it is clear. Have a nice and good day. Take care. Bye bye.